Hi, everyone. Hi, Dennis. Thanks for joining us. Appreciate it. We'll,
Dr. Garabin, good afternoon.
Hey, Sudha, how are things?
Hey, good. So many things going on in so many places.
I know.
It's hard to keep track of all the, everything. But we probably should just give some additional folks a few minutes to connect, and then we'll start. And as I kind of mentioned on email, this is a pretty small group, usually, a dozen people or so, students, residents, fellows, staff, folks who are working on education, innovation, research, work in variety of disciplines, cancer, injury, surgical skills, neurosurgery, just a variety of different things. People who are interested in policy. And then sometimes we'll have some of our clinical fellows and clinical faculty pop on who are, working around their clinics, things like that, and who are leading various programs. So people may come in and out. So we'll kind of give everyone a few minutes to catch up, get settled, and then we'll get started. And we just want to know all the great things that you're doing. So I want to learn from an expert here. So
Well, I think I would plan to just like have a 30-minute conversation or so, like a small talk, and then we follow up with conversation.
Yeah, that sounds great. So I'll just give another minute or two, and then if you don't mind, I'll introduce you, and then we can go from there.
So good to see you, Dennis. Thanks so much for doing this.
Okay, so I think we'll just get started. And we're also happy, Dennis, if you want, we're happy to kind of have everyone introduce themselves so that you have a sense of who the audience is. I think that might also be helpful. So before I ask everyone to introduce themselves, let me go ahead and introduce our speaker today, Dr. Denis Foretia. So Dr. Denis Foretia is a general surgeon at the University of Tennessee in Memphis. And he is very established in his heritage is from Cameroon, and he's very established there, having been the president of the Association of Cameroonian Physicians in the US, president and founder of the Cameroonian Professional Society. He co-chairs now, or has been co-chair of the Meharry Vanderbilt Alliance. He's been the national president of the Cameroon Student Association. He has had an extensive background in training. He got his bachelor's degree at the University of Maryland and did his MD at Vanderbilt. Went to surgical residency at Emory, where he was a global health research scholar. He has a public health degree from the Bloomberg School of Public Health at Hopkins and an MBA from the Carey School of Business at Hopkins. And he also is the founding director, I think that's the right term, of co-chair and founder of the Denis and Laura Foretia Foundation and the executive chair of the, I don't know how to say the name.
Incafu,
Thank you. Incafu Policy Institute, and through which he's really focused on ensuring that there is long-term sustainable change in the healthcare system in Cameroon. And Dr. Foretia kindly invited me to join his group. He's also the leader of the Center for Multicultural and Global Health at the University of Tennessee, and he invited me to be their keynote speaker a few months ago. And there's a really amazing group of professionals at the University of Tennessee who are really just thinking about not just global health, but local health and justice. And actually that particular symposium that I was part of really focused a lot on environmental and social justice and the impact of that on health and healthcare. For example, one of the things we talked about is, where does all of the used surgical waste go? Well, it goes to various parts of our cities and counties that are in poor neighborhoods, And so where are there incinerators for medical waste? Not in the rich parts of town, right? And so there are some real ties there that are interesting that we as surgeons and healthcare professionals don't necessarily always think about because they're sort of in the background. So that's how I got to know Dr. Foretia. And just after that, he launched a surgical scholar program. And I said, we must hear more from this man. There's a lot that he's doing. And there's a lot of inspiration that we can have from him. So with that, welcome and thank you for making time. And we'll just go around the room and just say a quick line about each of ourselves, just so that he knows who we are. So obviously, you know me. And so we'll do the online folks first real quick, and then we'll do the in-person folks. Tan, do you want to introduce yourself?
Yeah. Can you hear me?
Yes.
Cool. Hi, I'm Tan. I'm a senior majoring in health society and policy and international studies. I'm working with the Center for Global Surgery on education development and working with Anna, who's in this call, on developing the Intro to Global Surgery course.
Okay. Wonderful. Thank you, Tan. Anna?
I'm Anna Drelly Anderson. I am one of the programs managers over in the Center for Global Surgery, and my focus mostly on education.
Thank you. Laura?
Hi, good afternoon, and thank you, Dr. Denis. I'm Laura. I am a doctor from Colombia. I am also I'm one of the students at the MSCI program. I'm part of the track 3, which is the very first cohort, and it is related to innovation and technology to solve different global health issues. I'm basically working on a prototype for patients who had a decompressive craniectomy and are awaiting for cranioplasty in low and middle income countries. So we will see how it goes.
Okay, great. Thank you, Laura. Dr. Jerice?
Yes. Yes, we know each other. We shared a wonderful plane ride from Namibia, actually, I guess, through South Africa and back to Atlanta just recently with the COSEXA meeting. So we had a very good time then. I think you know me, but I was the founding director of the Center for Global Surgery, followed by Ray, and now currently Sudha. And I'm a pediatric urologist by clinical training.
Thank you so much, Catherine. Sarah Joyette is one of our ENTs. She said she just had to go take care of a patient, so she may have just stepped out. So I'll just introduce her. She's one of our head and neck cancer surgeons. And she has been on faculty with the Department of Surgery over the course of the last 2 years. She started roughly around the same time I did, and her division became a department in the last year, and so we've been strategizing, thinking about how to support the growth of global health global surgical work in her department. And brainstorming where there are potential partnerships with ENT surgeons. Okay, well, folks around the room, we'll just kind of, John, do you want to take the lead, and then we'll just go around?
Thank you, and great to be here with you. Look forward to this presentation. My name is Jonathan Nellermo, Programs Manager with the Center for Global Surgery, and this is a really wonderful group to be with. Thank you.
Hello, I'm Angel. I work here as a research scholar. I've been here for the past year working on breast surgery and minimal invasive surgery and transplant projects. I graduated medical school in Mexico, and I'm currently applying for residency. Nice to meet you.
Nice.
Dennis, Ray Price, good to see you again.
Yes, sir.
Okay, go
Hi,
ahead.
my name is Leif Sorensen. I'm an undergraduate scholar here at the Center for Global Surgery as well. I mainly work with Angel and Dr. Price in our Mongolia and Cambodia projects, specifically liver transplant, breast cancer, and minimally invasive surgery.
Hello, my name is Luis. I am a medical student from Mexico, and right now I stay here like to observer.
Wonderful.
Thank you, Luis. Okay, all yours. The floor is all yours. Thank you so much.
Dr. Jairam, and I really appreciate this opportunity to be invited to talk to the team on some of the work that we are doing, and specifically some of the work that we are focused on recently on a global surgery advocacy program, where we have some advocacy fellows for LMICs. But before I start, first, thank you, Ansuda, for your leadership throughout, from UCSF to, all your journey that you've gone. You have great fans, that in us here in Memphis, and we're very appreciative of all your work that you're doing. During the last college in San Diego, I was talking with a very nice stud, and he told me his name, Matt Price. I said, wow. And then he said, yeah, my father, is Dr. Price. I was like, wait a minute, which Dr. Price are we talking about? And he said, Ray Price. I was like, you must be kidding me. Ray is someone that we've only read about most of the time, and so it was really amazing. And then Matt said, oh yeah, my dad is here, do you know that? I was like, I don't know that. And within 2 hours or so, I was talking with Dr. Price. So you can imagine my excitement, and getting to meet Dr. Price in person, having followed his work throughout in Mongolia, what he has done in Mongolia, how him and Dr. DeVries really pushed for academic global surgery. So it was really a wonderful opportunity to get to meet Dr. Price. And as Dr. DeVries has said, we are leaving Namibia from COSEXA, and we are checking in simultaneously. and I was like, we just started talking. I said, Catherine DeVries. I was like, Catherine DeVries. So this is Dr. DeVries that I'm talking with. And so we had a very nice, nice dinner. And Dr. DeVries, thank you very much for your leadership, and a nice trip back to the States. So it is wonderful to have the opportunity to talk with the team, and to see the growth that the transformation from when the paper that I read back in early 2000 on trying to establish global surgery at Utah, at the University of Utah, and how everything that Dr. DeVries and Dr. Price had to do to make it acceptable, to broaden everything or so, to the point where it is currently. And it's not just that, but also the leadership in shaping the field in the Association of Academic Global Surgery. So I really appreciate this opportunity, to be here today. And as I share my slide, let's see, I hope this is it. As I share my slides, I really want to focus today for the next, I think it's going to be more of a conversation and that we'll have. But I wanted to just talk really briefly on policy advocacy in global surgery. Now, I wanted to focus on policy advocacy first because it's one of the areas that we are trying to push in sub-Saharan Africa and low and middle income countries, but also because when I was doing my MPH, I was really struck by a tagline. You know, they said the folks who were going through the school was the goal was to influence lives, change lives, but change lives millions at a time. You know, when you think about that, changing lives millions at a time. For us in surgery, it is usually one patient at a time that you change lives. And then when you are able to help in the hospital system, you can now change lives regarding the patients who are coming through the system to optimize care for a variety of patients. But when you think about changing lives and changing lives millions at a time, there's really no way that I see that except when you implement a policy change. Whether you think of it as breast cancer screening, we may have all the data on how to manage breast cancer, but if you don't screen early, then we know what the outcome is. Many patients come late, and then the outcomes are really poor. So the policy in place, convincing policymakers to be able to implement a policy regarding breast cancer screening, regarding colonoscopy and screening colonoscopies and all of that, and having to ensure that there is a system to make sure all groups of individuals, all groups of potential patients benefit from those screening opportunities is really important and is very transformative. So when you think of how you can impact, really impact lives for people millions at a time, you can't run away. Or I don't know, I think from the conversations, we'll have a robust debate about this. You can't run away from how you use policy to make that those changes. And so that's one of the main core thing that I wanted to stress, the importance of policy in surgical care, in global surgery, in medicine in general. Now, it's similar to when you think of an endeavor, an initiative like Safe Surgery 2020. How do you go about ensuring that surgery is safe, surgical care that is provided to millions of folks in low and middle income countries is safe? We know that there are areas of improvement, but how do you actually implement it? How do you actually get it from the data that shows that this is something that's good to when it is actually implemented, and where the outcomes from that implementation can be tracked, can be augmented, can be refined, and then you can have a next version of that. All of that, that process is in what we call policy advocacy, policy development, advocacy, implementation, and all of that. But most of the time for us in medicine and surgery, we are really not involved in this policy side. It is only recently, over the last decade or two, where even the American College of Surgeons has taken a strong interest in policy work. And sponsoring some folks through various scholarships or so to gain deeper knowledge into the policy arena, both for policy issues in the country, but also work internationally. When you think of how do you scale pre-hospital trauma care in places like Uganda, Rwanda, things that Sudan and you all have done very well, whether it's in Mongolia, the care being provided in Mongolia or so. How do you scale that? That is not surgery. That is not like operating on somebody. This is like working the system, the politics or so, to be able to ensure that folks who do not have the training can get the training, the systems of reaching patients can be optimized. The systems of transporting patients to, healthcare facilities, can be optimized. And at the same time, once folks get into the hospital facility, that, the systems in the hospital facility are optimized to ensure that the best possible care can be provided in a timely fashion for it. That is a long chain of processes. That is not how you do a Whipple, that's totally separate from that, but equally as important in ensuring that the delivery of care is as optimal as can be. So what is policy? I know there are folks here who are doing their masters and bachelors in policy, but it's simply a set of principles that represents the end results of decisions as to how best to achieve certain objectives. That's it. And in every policy, there is politics. There is politics in every policy, whether it's in the hospital setting or so. You want to implement a policy, it may take resources from one side in order to optimize the other side. And the whole issue of politics as well is really, the art and science of power, of how you manage, power. That is the core of what, politics is about. So with this policy, how do we then approach, policy advocacy? How do we build that strategy, the advocacy part, the strategy to build evidence and use evidence to be able to make the point? Because most of the time we hear that data speaks, but I have to remind folks that data speaks, but probably not loud enough. We know that the penetration of new data, they use the changes in implementation usually lacks about a decade from when we know that a particular procedure is more optimal than the other, but there is a lag time in accepting that change. Most of the time, just across the board, we are very hesitant to change. The early adopters to change are very few. We know that the early adopters are usually not up to 10% of us who say, "Oh, this is very good. So let's latch onto it. Let's figure out how to implement it." So how do you build evidence and use that evidence to influence people? First, to engage in the planning process, and then to engage and influence policymakers or administrators or whoever it is to be able to ensure that what you know to be good, what you know to be beneficial to your patients is actually what is implemented. That is that strategy in policy advocacy. And the end goal is to create, if there is no policy currently in place, or to reform or to change the current policies to ensure that it is optimal, so to speak. But we all know that as physicians and surgeons, we really do not have training in these kinds of arena. This is not what we talk about. We talk about generating the evidence, and we believe that the evidence is going to speak for itself. But my friends, we all know that that doesn't work. Now, what is a doctor's role in advocacy? What is the doctor's role in advocacy? And this is interesting because Richard Horton, back in 2002, he wrote a small op-ed in the Lancet where he said, doctors can no longer remain silent about their work, leaving advocacy to a small group of medical politicians. Doctors cannot assume that they have either the trust of the public or the support of governments unless they are willing to take part in public debate about what kind of society they want for the sick and the impoverished. It is very clear coming, post-COVID, post-pandemic, or even still in COVID, that the importance of doctors in the policy arena cannot be overemphasized. Knowing the process cannot be overemphasized, and knowing, it is very difficult to remove a bad law from the books. It's extremely difficult to change laws. So policy advocacy and good policy advocacy is to ensure that whatever is enacted in the first go around is very good, is based on proper science and research, and it can be appropriately implemented. So that is really the core, and one of the areas where we need a lot more medical folks focusing on how to to do that and do that well. Now, the process is very long. It's a full process, from even generating the evidence to like carrying it along to going to passing it to at the same time following up on implementation. We look at first identifying the problem. What are the problems that we are trying to deal with? For example, we are trying to deal in Cameroon currently on dealing in a conflict region, and how is surgical care in a conflict region, and what policies are is the government putting in place with NGOs, both in-country NGOs and international NGOs, to be able to appropriately care for patients in the conflict area. Now, we may think that that is just you showing up and doing doing the surgery, but as Dr. Price, Dr. DeVries, everyone would attest, this requires a lot more involvement in management and processes than the average surgeon would want to like deal with. But it's a process. The advocacy process, it's a process that ensures that we identify the critical nodes that can lead to or precipitate the changes that we are looking to to implement. Now, the frameworks are different. It is never an isolated internal environment. It's always both internal environment and external environment in any policy you do, whether it's as Suda has done in Rwanda with pre-hospital care. It is both internally within the hospital, the first responders, lay responders, the Ministry of Health, all this group of stakeholders who obviously have different training, different experiences or so, but they're trying to analyze the evidence and figure out what is logical, especially if you are in a context where policy can be made in a logical framework, where evidence can be counted. But at the end of the day, evidence is not always what is put at the forefront when political decisions are made. Interests at times take usually actually interests take over in the decision making, and so this policy advocacy part is to ensure that you can get through a lot of that and ensure that the real evidence, the real good policy that we know from the evidence that has been generated, gets to be implemented. Now, it's very dynamic, from identifying the main issue, identifying that, to then figuring out, what is the issue? How do you develop the policies regarding that? Whether it's screening issues or so, or who to cover for health insurance, or how to set up hospital referral systems for burn patients. All of that are key important things to consider. You obviously cannot run away from the political will. The political will is a major issue, and that has to be, to be dealt with and better understood if you are going to succeed. And then you bring all of it together and put together an action plan, but figuring out who your key, barriers are in implementing the policy, and how to, once the policy is implemented, how to evaluate that policy. But at the very elementary level, this is a very long, complicated process that has been simplified here in just these nice diagrams. But very complicated process that requires unique and varied skill sets to be able to make sure it can be implemented well. Now, one thing that I want to highlight here is the concept of the Overton window. Joseph Overton was the vice president at the Mackinac Center in Michigan, a public policy think tank, and he came up with what ended up being called the Overton window. And the opportunity window for any policy that we have, whether it's social policy to development policy to health policy, any policy whatsoever, at any time, there are a range of policies that are politically acceptable to the mainstream population at any given time. There is a range, and how you move acceptability within that range is what you do in policy advocacy, figuring out how you can take the key stakeholders and the politicians from being totally against, covering for, let's say, breast cancer screening, to flip the chart and everybody say, oh yeah, it is extremely good. We cannot be doing this without, covering that. Acceptability or so is something called the Overton window. And as you can see here, you see where a policy can start. When you think of something, you can think of the policy as extremely radical, unthinkable. You can't even do it, think about that. Or is it acceptable? Is it sensible? Is it popular? Is it, and you look at it from that spectrum or so. Most of the time, the change that we try to implement at the outset is always seen as radical because it's a change. It's a change, but how do you make it palatable? How do you humanize that change? How do you let people know that the change is needed, but at the same time, the outcomes, would be either better or not that very much different for it. But at the same time, it may be a little bit inconveniencing for the short run, but in the long run, it is extremely important for it. That is the work of policy advocacy. And we see this across the board, whether it's you trying to convince your department chair regarding like Dr. DeVries and Dr. Price regarding the importance of global surgery and the Center for Global Surgery. That requires not just putting the raw information here, but that requires creating a set of pressure points that shows the importance, the value creation that will come from such a center, and it becomes a no-brainer to administrators, to politicians, or so to be able to implement that. And usually, our main objectives are usually to how do we mobilize and maintain the current supporters of the project of the policy, to ensure that when you start going out there, you don't lose them. You got to keep the house. It's like a mother hen. You got to keep, the chicks all in order before you go out. You go out there. How do you minimize active opposition? Because every time you are doing a policy change, whether it is okay, this is the way we would start receiving patients when they come through the emergency department. There are definitely some groups, some departments, or some power bases that are not going to like that change. So how do you minimize active opposition to a change that you are convinced, based on evidence and other indicators, that it is good for the health system, for the surgical system, for patients, so to speak? And how then do you convert neutral parties, to join the fold? What are their points of interest? Becomes very important, for one, engaged in this, to identify those areas of interest, to be able to ensure that it's in alignment with the policy initiative that is being proposed. So that's very important. Now, when we look at global surgery and global surgery advocacy in low and middle income countries, it becomes clear that the vast majority of advocacy towards what we consider global surgery in LMICs, most of the time is led by HIC, is led by us in the high income countries, for a variety of reasons. For a variety of reasons, we know the system a lot more. We are more connected to the system. It's a lot easier, or we have resources to be able to make publications or analyze data and write about them a lot more than counterparts in low and middle income countries. There are pressures that we all know for our LMIC counterparts who are focused, overburdened with clinical care. and they can't really lift their head up to catch a breath. And now you want them to be at the WHO and the World Bank and all these places, learning the systems at times, feeling comfortable regarding what their place is, and then having the power to question some of the power structures there. It's usually not easy. So you tend to see where a lot of advocacy in global surgery, a lot of the ideas, well-intentioned ideas, is usually led by folks in HIC for it. And the question that we always ask is, where are the leaders? Where are the LMIC leaders? They are there for sure. We know from all the work that we've done in Rwanda, in Zambia, in Cameroon, in Nigeria, in India, everywhere, in Mexico. They are there. They are leading it. But are their voices being heard in the international ecosystem that decides how resources are allocated for various public health, global surgery interventions? Are their voices being counted? Or are they just relegated to the back bench and once in a while or invited to conferences just to make the numbers, to show that there was somebody from Ghana who was there, or do they actually are on the forefront? So this has been issues that we have really wrestled with. And recently, as we all know, we have all the data here on global surgery, the importance of global surgery, the current burden, the lack of access. And we all in this environment, we all know that. But we see that when you look at like national health strategic plans, I mean, look at those plans when it was reviewed for plans in Africa. Surgery and surgical conditions really did not, factor in 19% of all the surgical and
Oh, I lost him. Can you also?
in the plans.
Oh, here we go.
So,
Okay. Sorry,
so
Dennis, do you mind repeating yourself? You just cut out just as you mentioned that sentence. Do you mind just repeating what you said?
I guess can you hear me now?
Yeah. But
Oh,
you cut out
my internet was somewhat unstable there.
Yeah.
But you can see in the national health strategic plans that were reviewed, in 48 and 43 African countries, the mention of surgery, was, just 376 times in their national plans. And then HIV and malaria, you will think that the entire the continent is HIV and malaria. I mean, there's nothing wrong with HIV and malaria, or we don't have any beef with HIV or malaria. We love that it is being taken care of. But at the same time, who are those who are going to advocate for surgical care? A lot of work has been done on NSOAPs and the implementation of national surgical obstetric and anesthesia care, anesthesia plans in various countries or so. A lot of folks in the Harvard system have PJ, SCC have really pushed this and done a lot of work in developing these plans and making sure that it takes an active role part in the national health system. But when you even look at the progress in adoption of this, we're still very slow. We're making some baby steps or so. It's not easy. But how can we advocate better for surgical care in LMICs? How can we advocate better for it? And importantly, how can we advocate better? And that advocacy is led by folks who are experiencing, who know the day-to-day ins and outs of how surgical care is delivered in their country, in their own country, or in their region, who are the experts, who will tell you, the difficulties in performing burn surgery, who will tell you the difficulties in having, TPN, you know, for nutritional purposes or just IVs and things like that, who know the ins and outs of the challenges in that area. How can we ensure that they have, you know, the power? They have the power. Now, when Paul Farmer and Jim Kim, you know, and late Paul Farmer, they talked about surgery being the neglected stepchild. Yes, it was, and to a certain extent still is, but there's been considerable progress led by folks in here to make sure that has bubbled up to the international stage, and funding is now being appropriated, even though we are still not happy with the level of funding, but there has been tangible progress there. But again, who are those leading this, and is it translating to the national level and to the local level? Are we having that happen? Are we seeing that happen? Now, there is a public demand across low and middle income countries, obviously, for better healthcare, for better surgical care. That's across the board. There's been recent, you know, a lot of work regarding how we shift the center of global surgery, you know, to make sure that it's anchored in low and middle income countries, and rightfully so. How do we move from, you know, the operating room to ensure that our voices now, you know, really carry outside of the operating room? That is really the thing we are trying to address here. How do we make sure that we translate that from the operating room to the public sphere? And at the end of the day, advocacy skills are extremely important, you know, to be able to do that. And that's part of the reason why, you know, we have partnered with Operation Smile and the Carrefour Policy Institute, as well as the University of Global Health Equity in Rwanda, to launch this fellowship, which we call the Global Surgery Advocacy Fellowship. And the goal with the Global Surgery Advocacy Fellowship is that we want that in the next decade, we should have at least 150 passionate, compassionate, skilled, you know, global surgery advocacy leaders who are based in LMICs over the next decade. So basically, we want to clone Suda and, you know, Dr. Price, and make sure that, you know, they are based in LMICs. You know, they are based in LMICs, and they are advocating and leading in across the board within their countries, but also on the international scene. So that is really the goal of this. We want to identify and train global surgery leaders, again, based in LMIC countries, to ensure that they have the skill sets needed to be able to advocate for the policies that are important as far as global surgery, as far as surgery is concerned, where they are. And it is to ensure that they are empowered, you know, that we give them the opportunity for them to be able to prioritize, you know, surgical care for decision makers in their countries. We provide them with training in both grassroots and global advocacy. And we also ensure that they are part of a network of both really skilled, well-informed, very confident global surgery advocates, locally, internationally, to make sure that they are on the table. They are on the table, and that policies or decisions are not taken about how to influence a particular to implement something in a country without them on the table, leading that. So that's really the core of this fellowship that we launched, and that is ongoing now, to empower them, to increase their visibility, and create this platform for them where their voices now can start carrying, and we can ensure that, you know, they become strong advocates for surgical patients in LMICs. The core components of this program that we've launched is that first there is skills development part, then there is mentorship, and then there are, you know, there is a capstone advocacy, you know, project that we expect from each of them. This is how the skills development part is broken down. 2-week in-person training. I mean, the 2-week in-person training will start in Rwanda next month. There are virtual training sessions throughout the year, and then the various topics that we want them to really be good at, to learn. Very important in advocacy, how to write well, how to understand the political landscape, social media advocacy, how to mobilize, how to talk with the media and not run away, effective public speaking. These are skills that in most LMICs, especially in sub-Saharan Africa, folks graduate through their undergraduate and master's degree without very good public speaking, writing skills. And those are things that we really want to build up on as part of this fellowship. We at the Nkafumi Policy Institute, we run a week-long course, which is a public policy training course, and that course is really integrated into this into this fellowship. And it has different things on how you do policy research, the policy analysis, the impact analysis, how to communicate it, how to ensure good implementation, and then how to hold people accountable after a policy is implemented. Mentorship is very big as far as this is concerned. And we are identifying mentors around the world to mentor these fellows, and we clear expectations from both the fellows and the mentors as to what should come out of the relationship. And I would say the Center for Equity in Global Surgery has really been a core part of this, and our training in Rwanda will be next month or so, the first in-person training, and there have been a big entity in this transformation that we are looking. This is our first cohort of fellows that we have, really from sub-Saharan Africa and Latin America. And we are very much looking forward to welcoming them in Rwanda as they start this fellowship. Now the Capstone project, as I mentioned briefly, it would be very broad. We have examples of how you build coalitions, how you develop resources or so, and how you mobilize the surgical community. But the other thing is that each fellow will qualify for up to $5,000 in seed funding, to help implement their capstone, their capstone project. And this is very important because at the end of the day, to have impact, there has to be visibility, and to be sitting on tables and contributing ideas as to what policies need to be implemented to improve surgical care. You need some experience doing that, and so this is a way for us to be able to ensure that these fellows have developed that experience and feel comfortable in advocating the different policy initiatives or ideas that they have. This is our, a rundown of it, a timeline for what we have going on. But this is a nutshell of this new fellowship there, because we really, we believe strongly that you can have change, especially on something like, global surgery, when the folks who are on the ground are not empowered enough to be able to speak up and take the lead in the initiatives that are being implemented in these countries. And so at the end of the day, our policies in global surgery, they must be conceptualized and have to be led by our in-country experts. And our role as HIC-based allies is really fundamentally to support them, to support them, to create the networks for them, to ensure that they can take this and run with it, and we can all celebrate with them the wins that they are able to get. And the bottom line being surgical care for the 5 billion folks that we're really concerned about is optimized. So let me stop there also, and then we can, hopefully have some conversation on this. But, thank you.
Wonderful. Thank you so much. That was a fantastic talk. Really appreciate hearing about how you empower people around the continent and around the world to be advocates, when in many ways people have never had the opportunity to learn those skills and have never been part of that power dynamic. And so I think intentionally creating programs that bring them to the table and enable them to be active participants in decision making, is phenomenal. Can I ask you sort of the practical questions of how are these things funded? What is your plan for, 150 sounds great, starting with 5 sounds great, but how do you scale up something like this? How do you fund something like this? Because it's hard when there isn't a global fund for surgery to say, yes, give us funding to train all these folks who are this is critical. But there isn't a mechanism to fund it, and NIH certainly is only interested in research. There's no interest in funding anything that builds local capacity for advocacy.
Yes, so I mean, fundamentally, that is the key question of how the funding starts. But thankfully, through the late Paul Farmer and some of the funds that he had been able to generate, to support things like this, as well as the Operation Smile and their commitment, to ensure that they really anchor their work based on in-country leaders, in-country experts. So there is there's a great incentive on their part to ensure that they have the pipeline for folks who are well vested, who are well versed with the global system in health policy making, and the sub-Saharan Africa or the LMIC dynamics of it. So there are at the beginning, so we have this next couple of years that are mapped out, but we believe also that even the American College has been already shown interest for it. So we see that there are mechanisms that can be leveraged to be able to bring more visibility to the fellowship, and also bring more external funding, and as well as through private donations, private foundations rather.
Thank you. I'll open it up to questions, and I especially want to hear from Dr. Price, who is both on the advocacy committee of the American College of Surgeons Operation Giving Back, and our representative from the center to the advocacy meeting by ACS in April. And then I'd also love to hear from Dr. Denis, who helped set up an NGO, IVU Med, which is now I think going on its 20th or 30th year. It's several decades old now, yes. But in terms of becoming an advocacy machine to kind of rival the likes of Operation Smile, but for urologic conditions. And so I'd love to hear their thoughts, and then anyone else's thoughts.
Well, first off, Denis, I think you would be a great candidate to be on our ACS advocacy committee. I think you've just volunteered, so I think we should reach out. If you're interested, please send me an email, and we'll talk to Guillermo. We actually met this morning, and we're talking about who to bring on to the committee of the various advocacy efforts that we're going, and share with you those ideas if you're interested.
Yeah,
one of my questions,
Dr. Price.
Good, yeah. So please do send me an. And do you have my email?
I'll connect you both.
Okay, yeah, that'd be great. So if you could do that, we'll get you. You'll be some of our young blood to to do this. This would be fantastic. This is just a fantastic program. I'm interested in. This is done through University of Tennessee. Is that correct? And if it's through University of Tennessee, how have you advocated within your university to have them think that this program is a benefit to them as you are helping people within their countries as opposed to students and faculties at the University of Tennessee?
Yes, no, great question, Dr. Price. So there are two angles there where currently, the NCAFU Policy Institute is based in Cameroon, which I co-lead, based in Cameroon, and we provide a lot of the technical part of the fellowship. The whole training in policy advocacy and policy development, because over the last 5 years, we have run this short 1 week long intense policy advocacy courses. So we have modified that for this, for this fellowship or so. So that is one of the main angles. So that contribution is coming from the expertise and CAFU, but also we are drawing from my presence at the Global Surgery Institute here with our experts. We have 2 experts here in the policy arena who are part of this, of this fellowship. But then there's not been any need for us to convince faculty or administration on this, since they are not putting dollars to it, from the UT side. So that has been pretty much, that's very easy when dollars are not coming.
And so most of this organization is through your foundation in Cameroon from the Center for Global Surgery at UT, is that right?
This particular fellowship, yes.
Yeah, great, okay.
Well, I was interested to see that one of the incoming fellows, Patrick Maison, is from Ghana, right?
Yes.
Yes, he's we actually funded a fellowship for him to do pediatric training in South Africa. So
wow.
we do know Patrick, and now I can get on him to increase his advocacy in Ghana.
Yes.
Because Ghana is one of the sites that we are trying to promote a West African pediatric urology fellowship, because there does not exist one at all in West Africa. But he has had a fellowship, and he's one of the very few. So he is going to be in a very strong position if he takes up on it, and we can lean on him to do this, to become a center for the region. So thank you for showing who your current fellows are. So, but I think that this is fantastic, because we have tried to teach our classes how to do advocacy, how to do op-eds, how to get out in front of the public. But surgeons in general don't learn this. We've also found that public health people don't know anything about surgery. They may have had surgery themselves as patients, but they don't know anything about how the system works. And we in general don't welcome the rest of the medical community in to learn how it works. We talk a lot to ourselves, but we don't talk a lot to the rest of the people about how surgery works. And so people are sort of in the dark about this. And that's something that we have been trying to open up the doors and the knowledge. And I've got to tell you, it's not easy, because we have systems in place to not allow anyone else into an OR, just even to see what the dynamic of nurses, doctors, of all the different kinds of doctors, the different kinds of nurses and their different roles. People, even students, can't even come in and observe this to learn how this system actually even works. So one of the courses we teach at the university is on health systems. And another one is that is more directed to administration, has to do with surgical systems, because even within hospitals, many administrators don't know
Yeah.
what surgery it is and does, and who needs to be there, and what that whole ecosystem looks like. So I think this is great to develop this advocacy, and the capstone projects are going to be really important to be able to translate this fund of knowledge out to the people who otherwise don't have access, as well as to ourselves, because sometimes people who are even in the middle of working in the system don't know how the system works.
Yes, totally. I mean, could not agree more with that. The system is very opaque.
Yeah.
And then it's opaque, and there are very few of us who are even, out there, or I mean, even consider it like important enough to talk about it, or to even, write about it, research it, and figure out how to like make it work. At the end of the day, we just, we just outsource this. I think, we just outsource it to other people who have no clue what it's all about. So I think it's high time for us in surgery to, to not relinquish some of this, to speak for ourselves, basically.
Yes, and we often find that, because the nurses are paid generally by the hospitals or by the government or by some other entity, the doctors usually are not. We operate, we function together, but we operate on two different kinds of advocacy and motivation. And that comes down to money and who is paying whom to do what job. And if you're not in a private facility where you have control over all of that, then somebody else has control over very important aspects of what we do. And so we need to also learn where the money flows to make surgery work. And that's not a thing that doctors generally are taught, certainly not in medical school and often not in training. So we as practitioners can't even be good advocates in our own systems when the nurses all go on strike, because we have no idea what they get paid and who's in charge of doing that. So there are many aspects to this whole problem that you've been focusing on, that we all sort of obsess about. And I think it's terrific to have a dedicated fellowship, especially in the LMICs.
No, thank you for that.
Do you have a question on that?
Yes.
And Hal has a question.
So I have a question that is actually for all the experts in the Zoom, more for discussion. And I agree with what you said in the beginning, that it's needed to make changes in the system. And it's not only about going and training people, but you have to change sometimes the system. But I think that, for example, in one of the projects that I'm collaborating with, we've wanted to bring people to train in the US and then have them go back and implement this in Mexico. But it's sometimes the change is needed here in the US, and because as you mentioned, sometimes they can come here, but they can only observe, and they don't have like this hands-on experience that where they are truly learning and will be able to implement that in their country. So my question was, how can non-US citizens, for example, like me, get involved in advocacy here in the US? And the other question is, what are the platforms for people at my stage in training for getting involved with advocacy?
I think Dr. DeVries probably is knows this way better, on Dr. Price even, regarding advocacy or so. But there is really no limitation in you getting into advocacy, right? Like whatever you are advocating for example, if you want like Medicare cuts, like the current Medicare cuts or so that we're having, before you want to get into advocacy, you need to like try to understand what is it, how it functions, right? So you need to actually like know what you're talking about and what you're advocating for. So it means that by the time you want to go into advocacy for whatever, like you need to know the issues. So what are the issues in that you're trying to advocate for? What are the key issues or so? So it requires some deep learning on what the issues are, and then what are the options that you have. If you are saying you want less Medicare cuts, we all agree, less Medicare cuts. We don't want Medicare cuts. So we need to figure out how to fight that, how to like message that. What is our messaging for it? And who are the people? What are the downsides if you cut Medicare? So it's all about how you get the data and how you package the data, how you message the data, how you build coalitions for a potential policy that is being contemplated not to be implemented, and then for another one to be implemented. So I think that my direct response to you will be, first, you have no limitations. This is a very free country. You have no limitations, and you have to pick the issues that you are interested in.
Thank you.
I have a question for you as well. I wanted to thank you first. I think that was a very interesting talk. I'm probably one of the youngest here between me or Tan. I'm still in my undergraduate. So learning of what ways I can try to become a better medical professional is always very valued to me, because it helps me know where I'm lacking and things I didn't even think about, such as policy advocacy or trying to interact and find ways that I can use my skill set here to help those in other countries. And global surgery is a big passion of mine. And so I guess my question, building off of Angel's too, is if you were to go back to your undergraduate and you were to be 22 years old again, where would you get started? What would be the most valuable thing you think that you could do before even medical school or before you get to residency that could help build that skill set and allow you to become a better advocate for these countries around the world?
Well, that's a great question, but I'll tell you that in my case, I don't think I'll have to do anything differently, because let me in the sense that at the University of Maryland in Baltimore County, our president just when our president just retired after about 25 years or so, and he was this gentleman who knew just about every student. And walking down the street, he will call you, Dennis, how are you today? It was amazing. It was just amazing, Dr. Abrowski. So every day at 4 p.m., Dr. Abrowski met 4 students from 4 to 5. You had 15 minutes with Dr. Abrowski. And so his assistant, emailed me and said, Dr. Abrowski would like to meet with you. This was when I was in undergrad. And obviously he's the president, so he knows my grades, he knows everything, right? So I get ready and I go to the president's office. I have my best suit on that day. Like I'm meeting with the president. You kidding me? So I had everything in order. So he looks at my everything, looks at my grades, my performances. He said, Dennis, I see you want to be a doctor. And then he turns to me and he says, I think you will be a great doctor. And then he says, but I am not sure that you will be a great citizen. And I was like, whoa, what do you, I was like, okay, you don't think I'll be a great citizen? And then he says, well, I see you are doing all the physics, the math, the sciences, or so you're not reading, you're not reading history, you're not reading geography, or you're not reading the social sciences, the political sciences, and all of that. But to be a good citizen, you have to be broad in your thinking. When you get into medical school, you focus, but I need you to be broad in your thinking. And believe me, that's how that's how I end up reading a lot of philosophy and things like that. And I personally think that that broad base or so was very important for me in understanding various issues and not only like focus on the sciences. But that I have to credit Dr. Abrowski for that, because that's exactly what he said. And so I would say be broad in your in your reading. You know, yes, you're getting into medical school, but at the end of the day, you have to be a citizen first before you're a doctor. You know, so that's what I'll suggest.
Wonderful. What a
Thank you.
great piece of advice.
Yeah.
You know, we're already 10 minutes over. It tells you how excited people are about this topic. But I want to go to Dr. Rachel Koch, who's one of our trauma critical care fellows, who is a former PGSSC alum, or is a current alum, I guess, former PGSSC fellow, and engaged at UGHE. So Rachel, your comments or questions?
Yeah, no, I was actually just going to respond to the comment earlier about observerships and trainees visiting the U.S. We did a study actually when I was at Vanderbilt in residency with the Kajabi program and asked what people really wanted, and they all wanted to be able to come and do more in the U.S. And so I just wanted to share, Dennis, I don't know if you're connected still at Vandy, but they've actually changed the legislature for the state of Tennessee such that foreign trainees can come and get a temporary license to scrub and do things in the OR. So that's recent. I don't actually know if it's a law in effect or if they've been able to bring anyone yet, but you're in a good state for that.
Yeah, Dennis
and
knows
just-
Rondi.
Yeah,
We were
okay.
all at, Rondi and I both were speakers at his symposium a couple of months
Perfect. Sorry, I missed the beginning and all the connections, but
ago. No worries.
I just, yeah, different ways to advocate. And the group in East Tennessee who I've just gotten connected with is working on a sim center and new ways to do laparoscopy actually and cadavers with some new preservation technique. And so anyway, it's just been fun to think for me, connecting different people with new things that we can do. And I just think it broadens my view of what advocacy means in terms of how we train one another and learn from each other. So
Yeah, that's fantastic.
gonna share.
And by the way, that law, Ray Price and a bunch of other folks are working, including Rondi Kaufman, are working with the ACS to see if that law can be enacted at the federal level, so across all 50 states.
love it.
Yeah, there's some real interesting things with it, that there's challenges at a federal level and at a state level and at a local level. And we're trying to figure out how to address all of those, even though we've got this passed in Tennessee. The challenge is still just coming here on the appropriate kind of visa that allows them to even do that. So that's a big challenge, is the type of J1 visa to come into the country. So one of the federal things that we're working on is trying to look at either getting a new J1 visa that takes congressional approval, or if we can go for changing a J1, going through the State Department, that may be an easier way. And then it would allow some of these state things that get passed to be able to be useful, because they can't get here and with the right kind of visa, they can't implement those. And so at the state level, we actually have Scott Leckman going with the domestic committee, trying to see if they would be willing to really focus on the state level to do what Rondi's been able to do. And also actually Ohio's passed some legislation and some others over the last 10 years, and see if we can really make a difference, to see if we can't figure out how to do a bilateral equal exchange program that I think would really have great benefit for the world.
And we'll have Dr. Rondi Kaufman speak to us in 2 weeks about her experience in this works in progress meeting. So yeah, so we'll hear a little bit about her story in the state of Tennessee, the legislation there. So it's almost 4:15. So let's do one last comment, and then we'll thank Dr. Foretia. Tan, do you want to take the last comment?
I'd appreciate that. Thank you. Also want to thank you for sharing your experiences as well. My question is, are there any policies or approaches that can be implemented or done within a university setting that could enable global surgery by either increasing education opportunity or even access to global surgery?
well, I can refer you to papers written by, Dr. Price and Dr. DeVries on this. Okay. Because as we said, as I mentioned earlier, policies are always political. They are always political. So you need there are some policies that are in the direct interest of the universities. And then there are others where they would allow it to go because it's important, but it's not necessarily priority. So at the end of the day, like as was done at the University of Utah, is really understanding the landscape and then figuring out, how to massage and present different things to the key decision makers regarding, the importance of whatever it is you're trying to do, in this case, global surgery. For it, and it's a long process, but there's a lot that Dr. Price and DeVries have written about how to go about it, for it. So yes, but it's a long process, but it's a very doable process based on the fact that we are here today and that we are here at the University of Tennessee. It's the same thing that we implemented at the University of Tennessee, and we set this up, and next month, our partners in Zambia, a big team is coming to tour the entire university, and the president and the deans, they're all very happy. They have the media ready, for all of this stuff. So you have to like find what the interests are in at the university.
Thank you. And I forgot to mention Dr. Foretia is one of the main collaborators for the ACS Operation Giving Back Zambia Hub. So as a reminder to everyone, Zambia, Rwanda, and Ethiopia are the three main hubs from the from ACS. So great. Well, thank you so much for sharing the afternoon, evening with us, and humoring all our questions and getting us so excited. There's a lot that we can all learn from your experience, and we look forward to seeing great things happen from this Advocacy Scholar program, and look forward to working together in some ways. So thank you so much.
Oh no, Sudha and the entire team, thank you very much. Dr. DeVries, great connecting again. I will be in touch. Dr. Price and the entire team, thank you. And this has been great. Thank you all.
Great
Good
to
to
see
see you, Dennis. Thanks so much.
Thank you.
Have a good evening.